Namaskar and a very warm welcome, dear viewers, to today's episode of Young India Intensivist webinars. So today we have our international faculty webinar, and it is my great honor and pleasure to welcome Dr. Margaret Hayes to this webinar. She'll be talking on humanizing the ICU. So Dr. Margaret Hayes is Associate Professor of Medicine at Harvard Medical School. She's director of the MICU at Beth Deaconess Medical Center, BIDMC. She's co-chair of the Critical Care Executive Committee there. She's co-founder and co-director of the Center for Humanizing the ICU there. She's deputy editor of Chest Critical Care, and she has published numerous articles and won numerous coveted awards. She is also an active member of the American Thoracic Society, where she serves multiple educational roles. She is also interested in international education as a director for external education at the Carl J. Shapiro Institute for Education and Research, and has lectured extensively all over the world on humanizing critical care and medical education. So, ma'am, it is a great honor and pleasure to welcome you. Thank you so much for doing this. Over to you, ma'am.
Thank you so much for having me. I'm honored to be doing this with you all this morning for me, but I know evening for you all. So thank you so much for having me. So as you heard, I'm excited to talk about humanizing the ICU. I have no commercial or financial disclosures. My disclaimer, though, is that I'm not here to say that I have a human ICU and you do not, but rather to share some of the struggles from my group and share some of our ideas in a hope to really spread some things that we think are working and maybe give some warnings on things that haven't been working as well. My other disclaimer is that much of what I'm describing is related to ICU care and ICUs in the United States. So some of these things that I describe may not be directly applicable to you, but some of them I hope will. And please draw parallels with your lived experience and your practice. And I'd love to hear from you at the end to share experiences and really learn from each other. So the objectives for this talk for the next 60 minutes or so are to define human-centered care, identify humanizing and dehumanizing aspects of critical care, and then describe a framework for providing human-centered care. Whenever I give this talk, I like to start with this quote, "In the sufferer, let me see only the human being." And I think it's so hard for us in critical care to remember this quote. We often forget this, right? We often get so busy with dealing with resuscitation and de-resuscitation and dealing with all the documentation and dealing with trainees and families and everything that it's easy to forget this. And this is one thing that I really try to remind my trainees to always remember, that this patient is a human being. This is a person here, not a patient who had a life before us and will hopefully have a life after us. And how can we make this experience as humanizing as possible for this patient? So I want to start with the case, but unlike most talks, and maybe most talks that you've had here in this forum, it's not a patient case. It's actually a doctor case. So Dr. X is a 35-year-old male covering the ICU. He's caring for Miss A, who is a 90-year-old female with hypertension, COPD on 3 liters of home oxygen, heart failure with an EF of 30%, and dementia. Hospitalized now for 22 days, including 2 ICU admissions. She's back in the ICU with hypoxic respiratory failure, requiring non-invasive ventilation. Dr. X updates Miss A's daughter and informs her that her mother is, quote unquote, very sick and may need the breathing tube. Miss A says, "Do whatever it takes, doctor." Dr. X knows that he should talk about end-of-life care, but he doesn't want to bring it up since the daughter didn't. He doesn't feel comfortable broaching the subject, and he has no time since there are 4 admissions and 2 procedures waiting for him. Now, in the US, this is a very common scenario, especially admitting someone overnight when there's really just no time to do what needs to be done and to have these conversations. So this is a real patient story from our ICU at Beth Israel Deaconess Medical Center. And this patient actually died in our ICU. And we send out an FSICU, Family Satisfaction in the ICU survey, to the decedent's family members. And the daughter wrote this on the survey. Everyone kept saying that mom was really sick. I wish I knew that really sick meant dying, because then I could have been there. I was a new MICU director when this quote came across my desk, and I'll be honest, it crushed me. I was really upset. I thought, wow, we failed this family. We failed this daughter, and we failed her mom. Dr. X received that feedback from Miss A's daughter, and the combination of her words, his belief that he had made a mistake, and a busy ICU block crushed him. So we failed him too. And the nurses felt similarly crushed as they felt they were providing care that Miss A didn't want. So we failed them too. So I ask you, was this human-centered care? And obviously I'm setting it up as no, it was not. It was not human-centered for the patient, for the family, or for any of the care providers that were involved. And so before we then ask the question, how can we make this human-centered care? I think we need to define what is human-centered care. Well, the Center for Medicare and Medicaid defines it as integrated healthcare services delivered in a setting and manner that is responsive to the individual and their goals, values, and preferences in a system that empowers patients and providers to make effective care plans together. When we think about humanization or honoring the complete identity and dignity of another, we have to contrast that with dehumanization, which is viewing or treating another as less than human. And unfortunately, just by the nature of critical care, which you see in the picture here, many of the things that we have to do are dehumanizing, right? And we're not meaning to be dehumanizing. We're not purposely or intentionally doing that. But just by the nature of some of the interventions that we provide or the system of our ICU, there is dehumanization. And I really like this figure. This is from Critical Care in 2022. And you can see that there are so many things that cause discomforts and cause dehumanization. Shortness of breath, lines, tubes, sleep deprivation, hunger, thirst, isolation, noise. And these, you can see in this Venn diagram here, cause discomfort for the patient, for the family, and for all the healthcare providers. Fortunately, there's a longer list of humanizing behaviors, which you see here on the right side of the screen, than dehumanizing behaviors on the left side of the screen. And again, we're not purposely dehumanizing, but the nature of critical care is dehumanizing. So we, as intensivists and as healthcare providers in the ICU, we have to ensure that what we're doing is humanizing, that we are really being explicit about our humanizing behaviors. There's this nice framework. This is from the International Research Project for Humanization of the ICU that goes through this sort of this wheel of humanizing the ICU. These 8 things here: open ICU visiting policies, communication, well-being of the patient, presence and participation of relatives in the ICU, caring for healthcare professionals, prevention, management, and monitoring of post-ICU syndrome, humanized architecture and infrastructure, and end-of-life care. So these are 8 pieces that are essential to have a human ICU. And I just want you to pause for a second and think about your experience. Think about the ICU that you work in, or maybe the ward or clinic, wherever you are providing care. And I just want you to ask yourself, does your system, does your unit, does your ward, does your clinic have a system that allows provision of these 8 things? And just answer for yourself. And I will say, at BIDMC, we did not, and we still don't do a great job at all 8. And this is one of the reasons that we created the Center for Humanizing the ICU in 2022. My co-founder and co-director is Somnath Bose, who's anesthesia critical care at BIDMC. And he and I really wanted to create a system that humanizes the experience for all. And what our center is a collection of initiatives that humanize the experience. We include multidisciplinary collaboration, education, and research. And as of right now, we are all philanthropy funded. So we have donors who donate to our center to help fund our research and to help fund our initiatives. And I'm going to talk about our initiatives throughout this talk. But I want to go back to this wheel, these 8 characteristics of a human ICU. And I want to spend some time talking about each one of them. As we go through, I want you to keep in mind when I'm talking about them, I'm meaning care of the patient, the family, and the providers. So it's so important that we're taking care of ourselves as we're taking care of our patients and our families. So the first one is open ICU visiting policies in the presence of relatives. I'm kind of pushing them together here. In 2004, there was this commentary in JAMA from Don Berwick about restricting visiting hours in the ICU. And it was really a call to action. And he said, we should open up the ICUs and we should let family members in. And when I joined BIDMC in 2015, I was actually very proud that they already were having families join rounds and having family presence on rounds. And that was even before the Society of Critical Care Medicine had that as a major suggestion to have family members present on rounds. But then what happened? COVID, right? COVID happened and everything shut down. And we are not open up to the level that we were pre-COVID. Pre-COVID, we had unrestricted visitation. Family members could come and go as they please. You have to, call into the ICU and be let in, but we let them come all the time. We had sleep rooms in our ICU so families could reserve them and they could stay overnight and go back and forth from the sleep room into the ICU. But that all changed with COVID and it hasn't opened back up. We technically right now still have visiting hours. We make a lot of exceptions in the ICU, especially around end of life, but there are formal visiting hours. We know that visitor restrictions harm everyone. There is a lot of data about this and more coming from the pandemic, but we know that visiting restrictions harm patients, harm families, and harm us as the providers, right? We went through some really dark days when, we didn't have families at the bedside to help our patients through, and it was really challenging for all. We know, so this is the Society of Critical Care Medicine, the A to F bundle, and we know that the F piece is family engagement and empowerment. And I know I'm preaching to the choir with this group by saying there's so much data when we use the whole bundle, A to F, so many powerful things and improved outcomes when we're using the whole bundle. It's so important. Something that we've been trying to do since the pandemic. So these were two of our then residents at the time, and we came up with these communication tips in the time of coronavirus, and we still use them now. So something we do is make communication a daily to-do. So the residents will put it on their to-do list, talk to this family or that family. And we have to do that now because we just don't have as many families at the bedside as we used to pre-COVID. We do a lot of virtual meetings. This is one of the COVID silver linings, I think, that we learned. But it's one of those things that I'm like, why didn't we do this before? Right. So we're in Boston, our hospital, but we get a lot of patients from other states. And of course, there's a lot of family members that are working and can't take time off work, so they can't leave to come to the hospital. So we do a lot of virtual family meetings now. And we also have a policy and a process for documenting communication. So you can see this is a little template, a snippet of our template note, so that we can put in there, when did we have the conversation? Who did we talk to? What was the main substance of the conversation? So that then the next team can sort of pick up on that and can really make sure that they're continuing the communication course and that they understand what the family or what the loved ones have heard. So that moves me nicely into the next piece of this wheel, which is communication. So there is a history of poor communication in the ICU. We know from many studies that 30% of ICU families are unhappy with communication, 50% do not understand the diagnosis or prognosis, and in audio recorded family meetings, physicians spoke 75% of the time. 75% of the time. If we, the physicians, are speaking all the time, that's not leaving opportunities for the families to speak. It's not leaving us opportunities to listen, which is so important. And I'm pretty excited about the use of AI in this space because I think there's going to be more and more data where we can use some ambient listening and then give physicians their feedback in real time to say, in this family meeting, you spoke X% of the time. This is so important. This is such an important piece of our job that we often don't do well. This is a multi-society guideline from 2015, and you can see here that this document says that communication skills training is needed for all. And again, I just want to ask you and question for yourself, have you had formal communication skills training? So when I give this talk to physicians, most of them say no. When I give it to fellows and residents and trainees, they say yes. This is more commonplace now in medical schools, but it wasn't when I was in medical school. So it's so important to think about this and think about your ICU. Are your faculty members and are your nurses, is everyone trained in communication? And if not, how can you set up a communication training program? The document also suggests that we should have supervision and observation for family meetings, that we should capitalize on communication expertise from our social workers, our spiritual care providers, and our palliative care providers, and that there should be a protocol for communication challenges and disagreements. And this is something that we do have in our ICU. We also do a dedicated communication skills training for our interns and residents. So we have a 4-week curriculum when they rotate in the ICU. They are pulled out for 1 hour each week, and we go through a standard and structured curriculum for them. We have family member volunteers that you see in these pictures here. So these are people that volunteer to do this work with us. So they role play family members. We teach them about the case, and we give them, feedback on their acting skills. And then we also train them how to give feedback to the trainees. And there's always a faculty member there too who does most of the feedback as well, but it's really nice for the trainees to get feedback from the family member volunteers. And we teach sort of basic skills, if you will, but it's so important to do this skills practicing. We really are teaching our interns to think about patients as people, use ask, tell, ask as a communication technique, use simple language, respond to emotion, this idea of emotion before cognition, appropriate word choice, and we teach them how to run family meetings. And we do this now for our interns. This is work that was done before I joined BIDMC that our group had studied. And what we did was survey the family members after our residents did family meetings, and found that the residents who participated in 2 to 3 of the course sessions, the families were more likely to rate them as meeting their emotional needs. So the training mattered, the training helped, and we were pretty proud of that. We also do advanced training for our residents. So our interns get that basic training where, thinking about patients as people and using ask, tell, ask. But then we elevate it for our residents, and we teach skills like telling a family member their loved one is dying, managing conflict in family, and responding to miracle and God questions. One thing that we like to do is use this approach from this Lakin and Jacobson paper, where we say we want to balance our hope and our worry. We teach our residents to say that phrase, we want to balance our hope and our worry here, so that we are appropriately sort of warning family members that their loved one is sick, but not taking away all that hope. And I think back to that patient that I started this talk with, if we had said those words to the daughter, if we had said, we're really worried, but we need to balance our hope and our worry, would that daughter have been there? Would she not have missed the opportunity to be at the bedside when her mother had died? We studied this as well. So we did a study teaching residents how to talk about death and dying, where we randomized them to receive either a simulation-based session, so they did some role-playing and family meetings, or a didactic-based session where we just talked about the importance of saying death and dying, and a little bit of skills practicing by actually using the word, which is so hard, especially for our trainees, to use the word dying. And what we found is that those that participated in the simulation were more likely to learn new skills. We do a lot of faculty development around this. Many of our faculty who teach in our communication and our resident communication courses, we do a lot of teaching for others as well. We're working hard to standardize communication, to really say within, the first 48 hours, there has to be a sit-down family meeting. It's probably a little bit surprising, but maybe not to you all, a group of intensivists. It's really hard to define what is a family meeting. So does a conversation in the hallway count, at the bedside count, or do you need to be in the quote unquote family meeting room? So it's a little bit hard to standardize this and to do formal research around this when we're trying to set kind of standards and look at the feasibility of having a family meeting within a specified time frame. We do a lot of resident training and supervision. I already showed you the actual curriculum and the training that we do for our interns and our residents, but we also are doing observations of family meetings. So ensuring that there's faculty in the family meeting and that they're giving the residents real-time feedback right after the family meeting. Our social workers help with this a lot too. do and are excellent at this. And we're also doing a lot of faculty development to help faculty give feedback to the residents on communication skills, and also teaching faculty to do a pre-brief prior to the family meeting and then a debrief after. So I want to move on from communication and go to end-of-life care, this next piece of our wheel here. So end-of-life care is a common part of ICU care. So here in the US, 1 out of 5 Americans die in an ICU. 30% of Medicare beneficiaries receive ICU care in their last 30 days, and 58% of in-hospital deaths include an ICU stay. So managing death and dying and managing end-of-life care is a huge part of our job as intensivists and something that we should do well. In 2015, the Institute of Medicine came out with this report called Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. This was in 2015, so over 10 years ago. And the report says that improved care for people near the end of life is a goal within the nation's reach, and that it's a matter of professional commitment and responsibility. That was 11 years ago, and we are still not there. This is still something that we struggle with globally, definitely in the US and in Boston for sure. So what are the challenges? Why is this such a problem? Well, there's a reluctance of patients, families, and physicians to explore death and end-of-life issues. This is, I think, a problem across the world, but very specifically a problem in America where we just reject death. People don't want to talk about it. Even the words that we use. Now, I was watching a YouTube video recently, and someone was saying, when you think about the words, when you say, we're sorry you lost your father, you didn't lose him. You lose your keys or you lose something else. Your father is dead. Why can't we say that? Why can't we communicate that? I'm so sorry that your father has died or that your loved one has died. So this is a huge problem for us. There's also a fragmented healthcare system, and it's easy to just, what we say, pass the buck or make it someone else's problem. So when I'm in the ICU, I know I should have this conversation, but they're getting called out to the regular ward. Let them deal with it. Or, they're getting discharged. Let the oncologist manage it. Let the primary care doctor manage it. Let someone at rehab talk to them about it. Things are so fragmented that we often miss these opportunities. There's also poor quality communication. I already showed you the data on that. And there's inadequate structural support and a lack of training. If we were all together, I'd have everyone raise their hand, tell me how many people have not had formal training, and I bet a lot of hands would be up. This is a huge problem. We need to train people to have these conversations and to do them well, right? In my mind, this is just as important as placing a central line, arguably more important, right? And oftentimes we send our most junior person to go have the conversation while the senior people are cannulating for ECMO or doing other interventions. So it's so important to really rethink the way that we practice and re-emphasize the importance of communication. This is from the New York Times. This is a code death for dying patients from Jessica Zitter, who's a palliative care physician and intensivist in California. And she has written a couple books and has documentaries and really thinks a lot about end-of-life care. And she says in this piece that we physicians need to learn the ancient art of dying. And I love that quote so much. We physicians need to learn the ancient art of dying. And she talks about what this entails. Well, it entails the recognition that it's time to shift, or knowing when to offer care that's focused solely on comfort. So knowing when someone's dying. It requires the technical skills to help someone die well, and it requires honoring death and providing a dignified death. Let's talk a little bit about that. This is a nice piece from the Annals of ATS from Jack Awashna, recognizing a patient is acutely dying. And you might think, well, maybe this is easy, right? Do we need an article on this? But it's actually not. If you even think about your own practice patterns, you probably disagree with your intensivist colleagues. I know that I do, and saying, this person's going to die. They're never going to make it out of the ICU. And someone else may have a totally different take on that case. So it's challenging for us collectively as a community of intensivists to really be able to recognize the ones that are dying right in front of you. Those are easy, but the ones that, we're not sure about, it's really hard to recognize that. It's hard when we have trainees, who should be prognosticating, who should be talking about this. And I think it's so important on rounds as a team that we all talk about this so we have a shared mental model, and really important to have the attendings actually be the ones who are doing the prognostication. And we actually studied this. So in those family meetings that we had when we did the simulation project, we audio recorded them and then transcribed them and came up with challenges and barriers to talking about death and dying. And, one of the main challenges from our trainees specifically was that they had discomfort with the patient's prognosis. They were afraid to prognosticate. They felt that they didn't have enough experience. And in many times, I'd agree with them. That's why it's so important for the attendings to be able to talk and have these conversations and be open and honest with the trainees so that, again, there's that shared mental model. There was also a challenge that, the trainees feared the family's reaction. They were worried that they wouldn't be able to establish rapport with the family. They were concerned that families didn't want to hear the word dying. And I'll never forget in one of our simulations, the family member volunteer, she started crying. She was banging her head on the table and she was visibly upset with the news that the trainee was telling her. And after the simulation ended, when I was debriefing, I said, "How did it go?" And he said, "Terrible. Look what I made her do." And for me, that was a big learning moment to really shift the way that we think and talk and teach this. It's not terrible. It's hard. It feels bad. It's uncomfortable, but it's important. And the fact that this family member was crying means that she probably heard it. She got the message. And so we need to support our trainees. How do we help them have these family meetings? How do we help them sit with this challenging news? How do we help them support the family members while they're protecting and taking care of themselves? So important to think about the trainees if you work in an ICU with trainees and how we can support them in this. I think we need explicit recognition of emotional challenges and burdens, so pre-brief and debrief. And after that anecdote that I just told you in the simulation, I do that now. And I say, like, what are you worried about in this family meeting? And, how do you feel when you're delivering bad or difficult news? Teach the residents and teach all of us how to respond to emotion. So naming the emotion, recognizing emotion before cognition, recognizing the underlying meaning of emotion, and using silence, I think is so, so powerful. I have the opportunity to write this blog a few years ago about sitting with suffering, and it's really just sitting there in silence. We all want to fill the void. We want to say something, but just our presence is what's really important. And that can be hard to do. So how do we teach people to get comfortable really sitting with that suffering? I also think it's so important to reframe what we do. And I love this quote from the president of the Canadian Society of Palliative Care Physicians, saying, "If physicians can grow their capacity to have these conversations, they will increase their feeling of connection with some of the people they're serving. It will ultimately help their jobs be more rewarding and more meaningful for them." And when I'm on service and we have a challenging death, I tell my trainees and those that I'm working with, like, it's an honor and a privilege to bear witness to this and to help someone die well and to help the family. Ideally, we can just make it a teeny bit better and remember that the families are going to remember us for the rest of their lives. They're going to remember this day for the rest of their lives. For us, it's just one day of work, but it's such an important and meaningful time for the families. And if we reframe that and make it as important, again, as, putting someone on an ECMO and doing all these other things, I think it will help us. It will help us make meaning. It will help us feel more comfortable with the sadness and the heaviness. So the technical skills are really important when we're thinking about end-of-life care and helping someone die well. This is just an example of our comfort-focused end-of-life care checklist. So we have this checklist so that everyone can sort of go through and ensure that, the family's needs are met. Do we have the appropriate chairs in the room? Do we have compassion cards that we bring in? Do we have all of that stuff there? We also need to think about some of the clinical things. If this patient is paralyzed and on high vent settings, have we stopped the paralytic? Have we reversed the paralytic? Do we have the right sedative meds? Do we have everything that we need from a clinical perspective in the room? And then, have we talked to social work? Have we talked to spiritual care? Have we talked to our organ procurement organization, et cetera? So important to really have either a checklist in your record system or a paper checklist to go through. We also are a part of the Three Wishes Project. So the Three Wishes Project was started by Deb Cook in Canada about 12 years ago now as a way to sort of offer meaningful memories at the end of life. So Three Wishes means for the patient, the family, and the provider. And it's a way to offer what we do at BI is meaningful keepsakes to family members. So you can see the picture on the left. This is a small glass bottle with a heart charm, and in it is a rhythm strip that's rolled up. So we give these bottles to family members after their loved one has died. These are called a piece of our heart bottles. And then we also have fingerprint keychains that you see down here. So we have small ink pads, and we can get fingerprints and put them in these keychains and wrap them up in a nice little bag and give them to the family members. These offerings are very common in pediatric ICUs. And when we formally joined Three Wishes and rolled this out a few years ago, I was surprised at how many family members really liked this initiative. Especially the fingerprint keychains are really popular for grandchildren. So if their, grandparent dies in the ICU, this is a nice way for them to have a piece of their grandparent forever. And you can see some of the quotes here for our unit coordinator. She said, "To be able to offer a small source of comfort during a difficult time makes this program worth more than I could imagine." And our resource nurse said, "The Three Wishes Project has given families something to physically hold on to during such a difficult time. As a nurse caring for a dying patient, it's nice to have something to offer families as their loved one is passing." So in addition to the Three Wishes Project, we also give out sympathy cards. So the Center for Humanizing the ICU has created these sympathy cards. This is an actual picture of ours on the left-hand side here. And inside it says, "On behalf of the ICU team, we extend our deepest condolences for your loss. It was an absolute privilege and honor to care for your loved one. Our hearts go out to your family during this difficult time, and we are here to provide support in any way we can." And after someone dies, we all, whoever's on that day, will write a little note and sign this card. Sometimes we'll give it to the families as they're leaving. Sometimes, especially if it's a patient who's been in our units for a long time, we want to keep the cards to make sure that everyone has had the opportunity to sign. And then we'll mail the card after the fact to the family's home. We get calls back from families thanking us for this card. Thanking us for taking the time to do it and thanking us for all the care. And it's a very small act. These are, cheap to get printed, but I think a really powerful intervention here. So the next three pieces of the wheel I'm going to put together: well-being of the patient and a humanized infrastructure, I think go together to help care for the providers. Because I truly believe that as we do all these humanizing interventions, as we make more meaning in our day-to-day work, and we go back to that reason of why we became doctors to begin with, that's a way for us to take care of ourselves and take care of each other. So when we think about this, I love this concept of the platinum rule. So the platinum rule, unlike the golden rule, is doing unto patients as they would want done unto themselves. And sometimes it's hard to remember this, right? We throw out these buzzwords of this is goal concordant care, but it may be really hard to provide that goal concordant care. It may not be what I would want for my mother or my father, my brother, my sister, but reminding ourselves that we should do unto patients as they would want done unto themselves, I think is so important in remembering this platinum rule. So how do we do that? We have to know what the patients want. We have to know about them. So there's this concept of the Get to Know Me board. This was published in Critical Care Explorations from the Mayo Clinic group. And you can see here, there's, write the patient's name, what do they like to be called, and then some of their favorite things. This is an example of our Get to Know Me board. We call it an All About Me poster. So we have these posters hanging in every one of our ICU rooms. So we say, what do they want to be called? So you can see right here in the middle, hello, you can call me. We have this translated in a couple of our common languages. This is Spanish listed here under the English version. We ask them, what would you like everyone caring for you to know? What are you proud of? And we see wonderful things on this. People are champion tennis players in the Olympics, have, 20 grandchildren, things that are really proud. What sort of makes this patient tick? How do they like to spend their time? What music do they like to listen to? And we will often put that on in the computer in the ICU room. What do they like to have on TV? So do they like to, keep a news channel on? Do they like to watch sports? We can put all that stuff on here. In the middle, you can see we have items for assistance. This helps us mitigate delirium. So making sure that if they have glasses, we're putting them on, we know where they are, hearing aids, contacts, walker, cane, etc. And then we ask them, what hand do they write with? So as they, start maybe to come out of sedation and are starting to wake up, we can really help bring them back to the person that they were. So this we find really powerful and important. The way that we operationalize this is whenever there's a new admission, this paperwork is with the admission packet, and we'll have sort of the intern or resident or our advanced practice provider, whoever starting the admission, start to fill this out. And then we hang it on the wall and we invite everyone to fill it out. We sometimes will give this to family members too, especially anxious family members. If they're waiting for a little bit in the waiting room before they can come in and see their loved one, we'll say, hey, fill this out. Help us get to know your loved one as a person, not just a patient. And they'll fill it out and they'll bring it back in. And family members will add to it when it's on the wall too, and friends will add to it as they come, which is really nice to see. We also utilize ICU diaries. We've been doing ICU diaries for about 3 years now. The ICU diaries, lots of research has been done on this, and you probably are familiar with this space. But from this systematic review and meta-analysis, we know that there's a decreased risk of depression in patients. There's preserved quality of life in patients. And, the jury's still out on what's the effect of the diaries on families and relatives. So hard to really know, but we, put these diaries in all of our patients' rooms. This is our actual ICU diary. So this is the cover photo. Inside is this inscription. So this is a photo from a patient of ours. He's a photographer. He died in our ICU. So you see here, cover photo by David M. Gold, a generous and loving family man with an entrepreneurial spirit, a vibrant personality, and a beautiful smile. David lit up any room with his positive energy, even during his time in the ICU. This photograph was shared with love from his family for all to enjoy. And we were pretty proud of this because it sort of came full circle. When we started creating these diaries, we were looking online for stock images of, an ocean or something calming or cooling. And then this patient's sister had offered us to use one of his photos, and we thought that was perfectly fitting and perfectly suiting, and we loved the image of the butterfly. So we have the diaries in every patient room, and everyone is allowed to write in the diary. It is not part of the medical record, and it's not intended to communicate, real medically heavy info. Things like the breathing tube came out today, you stood up for the first time today, you went outside today. Those things are really important. And friends and family members, when they come, they'll write in the diary as well, like notes of good wishes or get well notes, etc. And the diary essentially serves as a reminder, a way for the patient to put together their whole ICU stay. So it can help with PICS and recovery. And also, if the patient does die, it's something that the family members can take with them, and they can have that reminder of everything that went on. So we find these pretty powerful. Our long stay patients really enjoy these, and we hear stories that family members take them home at night to read them, and physical therapy is writing in there what happened, the ICU team is writing in there what happened. There was a great story on social media where a patient had pretty bad PICS after his ICU stay and was feeling like, oh, I remember being in a war zone and there were bombs going off. And then when he read through his diary, it was the 4th of July and he was in a room, right? He could hear the fireworks and you could see the fireworks from his room. So he's able to make those memories make sense, if you will, when he was able to read the diary. So I think it's important. And I think there's going to be more and more data coming out on the ICU diaries. We also are very lucky that we have an embedded chaplain in our ICU. So there's a chaplain that is there that's able to get to know our staff, get to know our patients, and really get to help us help the patients. And this was a framework that we put together for CHEST a few years ago. This was one of our fellows, Laura McNamara, who took the lead on this, and really just giving guidance on in small but important things that the chaplains can do and how we can incorporate them into the team. And we really do view the chaplain as part of the ICU team, which has gone a long way. And we're lucky that BIDMC really has prioritized staffing a chaplain in the ICU. So this goes back to a slide that I showed you earlier, these dehumanizing sort of behaviors, if you will. So loss of identity, loss of ability to communicate, and all of these sources of discomfort. too much light, too much noise, uncomfortable bed, lack of sleep, thirst, hunger. And what we wanted to do was try to take sort of these most awful ones and these most common ones and see if there were small ways that we could mitigate these discomforts. One of the most complaints is about noise. And we've heard this from our patient family advisory group after they leave the ICU. And we just hear this in the ICU as well, that it's so loud. And we know when it's loud, people aren't able to get the rest that they need. That's contributing to more delirium, etc. Background noises in hospitals frequently exceed 45 decibels, and the World Health Organization says that it should be 40 or less. So what we did was actually just create this figure, this little graphic or infographic that you see here, and hang these up in the unit, just as a very passive educational intervention so that people could get a sense of, oh, wow, like a soft whisper is actually 40 decibels. That's where you should be. My normal talking voice is louder than that. And when two people are having a conversation outside a patient's room, that's really loud and disturbing. So again, this was just a very passive and educational intervention. We hung these up, and then we bought these yacker trackers that we call them here. These are just from Amazon. And what you can do is you can set the decibel level for each of them. So when you're getting loud, it can start blinking yellow. And when you're really loud over where you want to be, it can blink red. And it's just a quiet sign to say, lower your voices and keep your voices down. And this is something that we've rolled out in our units, and it's been really helpful and really powerful to, help ensure that our patients are getting good sleep at night. We also have an intervention called the Home Initiative, which is humanizing offerings for the medical environment. So any patient that is persistently critically ill, defined as 10 days or more in the ICU, it has the option of one of these sort of initiatives on our home list. This is almost like a menu, if you will. This is not patient facing. The reason for that is that, of course, not all critically ill patients are going to be able to have each of these interventions. So time outdoors, not everyone can go outside. So what we do is our resource nurse will screen everyone who has hit that 10-day mark, and then they continue to get rescreened every few days to say, what would this patient or family member benefit from? What can we do to make this environment more comfortable and more like home? So you can see in the pictures here, we set up a little fancy dinner for a patient. This was a patient who had interstitial lung disease, who was dying in our ICU. She was on high flow nasal cannula, so she was wide awake. And she used to have a weekly sort of fancy dinner, she called it, with her nephew and her husband. So we put a sheet on the bedside table. We folded sterile towels to look like fancy napkins. This was around the holidays. So you can see there's candy canes. We have little LED tea lights there. And we ordered in a nice meal for her and her nephew and her husband to have there in the hospital. We also have volunteers who come for music therapy. So this is Ricardo, one of our volunteers, who is playing the keyboard in our Fenard ICU, which is one of our ICUs. We also, offer cozy blankets. We have decals that we can put on the windows to decorate it. Time outside, which I'll talk about in a second. Special visitor considerations, so we are strict with not allowing children in the ICU, but if there's a special consideration, we're going to make that happen. If someone has a grandchild that they haven't seen, we'll think about a way to make it safely happen for both the patient and the grandchild. Special meal, I already talked about. So this is the list that we have here. And again, a little bit of a menu that's not patient facing that our resource nurse will go through and do. And you can see, since this is the newest initiative since we started it, you see the number of our patients enrolled here. And we've offered 109 comforts, 48 cozy blankets. So we have a volunteer from our patient and family advisory committee. She was in the ICU for a long time, who will donate these kind of warm, fuzzy, non-clinical blankets. We decorate patients' room. We do a lot of pet therapy and a lot of pet therapy visits. We also take critically ill patients outside. So we have a policy now to do this, that our Center for Humanizing the ICU led the work in creating this policy at our institution. And so what we do is we screen people the night before and say who may benefit from going outside today. or tomorrow. And then the morning, the resource nurse and the respiratory therapy supervisor will sort of look together and say, do we have the staffing to accomplish this? Can we safely do this? And if so, let's figure out a time to get this patient outside. So this is a picture of a patient outside in the front of our hospital with a respiratory therapist and a nurse here. And then this is a picture of a patient in our healing garden, which is on the roof of one of our connected buildings. And this was a patient who he's young and he was on ECMO for about 50 days. And then he was in the ICU for 30 days after that. And there was a lot of challenges with his sedation and, getting him to quote unquote, like participate in care. And after he went outside, everything changed. The nurses said prior to that, like he was refusing certain care and certain interventions, but after that, like everything changed. And he was just sad, lonely, demoralized. But you can see he's here with a group. These are two of our advanced practice providers, a respiratory therapist and a nurse. And he is on a travel ventilator. You can see that he's trached, but he is vented. He's on the travel ventilator. There's emergency medication go bag, and there's a portable monitor there. And then he's wearing one of our comfy, cozy blankets that we hand out in addition to the hospital blankets to make it something that's a little bit more comfortable and a little bit less clinical. We have a lot of data from our patients and families that they really love being able to go outside. We obviously can't do this all the time in Boston, so there are only certain months we're a little bit restricted. But when we can, and when the patient is safe enough and stable enough to go outside, and now that we have the policy to really guide that, everyone feels more comfortable getting these patients outside, which is great. So you can see some of these quotes here. It was so great, really made me feel normal. I wish every patient was able to experience it. It was amazing to feel the sun. The air is so fresh and clean, I can't believe it. It makes me feel so alive. This is such a great day. This is a new start for my granddaughter. Something else that we've done is really try to humanize the waiting rooms or create welcoming waiting spaces. So in our waiting rooms, we sort of reconfigured the chairs to have little special small little groups so that there is privacy for the families. We have a magazine drive in our ICU. So when people are done reading their magazines, they can bring them in and we can recycle them and we can stock the waiting rooms. We have a QR code in our waiting rooms to say, how can we make this better? What can we do? Now is one of the biggest complaints, like have updated reading materials. That's what the family members wanted. We have games and puzzles. We have cell phone chargers. We have posters that you see here with QR codes to get to visitor resources as well as mindfulness apps. We have this cart here. This is our family meeting cart. So this is in our family meeting room. So there's bottles of water. There's comfy tissues, Kleenex tissues, not the hard ones that the hospital gives. There's little notebooks and pens and then hard candy. So we're really trying to humanize the space for the family members. This is a coloring poster that we have in the waiting room on the wall. And when we first reconfigured our waiting room to make it more comfortable, we put this up. There's a little basket of colored pencils that are affixed on the wall next to this. And what I did was when I hung this up, I just colored in one little circle, one little dot, and just to signify to everyone that it's okay to color this. And every day, more and more people were coloring it. But what was really amazing, as you can see here, people started organically. We didn't tell them to do this, and I didn't write anything. I just colored in one little circle. People organically started writing these messages here, which were so amazing and so inspiring to see. And you can see here, rest in happiness, love you, stay strong, you got this. These wonderful messages. And this was a way to just create community amongst these anxious people waiting in the waiting rooms. And it was really a very small initiative. These cost like less than $10 on Amazon. And what we've done now is we've framed them all once they're completed and we've hung them on the walls outside our ICU, as you can see here. And we have this plaque here that says, thank you to our patients, family members, and visitors who bring such vibrant color to our walls and into the lives of our hospital community. Your care, presence, and love are felt long after you leave. And we see family members and docs and nurses and everyone just stopping and looking at these and reading the notes. And it's so uplifting. We actually published in Intensive Care Medicine on this, how a coloring poster transformed an ICU waiting room, a very small, cheap intervention that really has gone a long way to humanize the space and to signify to the families that we care. We're here for you, and we want to help you get through this really awful time. So the next piece of this wheel is monitoring for PICS and PICSF. So post-intensive care syndrome, something that 50% of our patients have. And we know this is defined by new or worsening symptoms in one of the following after critical illness: cognitive function, psychiatric function, and physical function. So what we do is we really try to ensure that there's awareness of this for all of our staff in the ICU, so that everyone is talking about this and normalizing it for the patients and the families, that you will likely experience this. Here are some things we can do to make it better now. Here are some things we can do to make it better after. So really make sure there's awareness for patients and families. In our ICU diaries, the first page has information about PICS, and then the last page has information about how to get plugged into our post-ICU follow-up clinic. And, if you have a survivorship clinic, great to refer these people to. If not, make sure that they're getting referred to the appropriate consultations. So we do have an ICU survivorship clinic that is run by one of our faculty, Kate Berg, as you can see here. And if we, the ICU attending, want to refer a patient, we can email her and get them plugged in. She also does a lot of screenings on her own to say these people would benefit and these people should come to the post-ICU clinic. She also does this really lovely thing where after she sees people in her post-ICU clinic, she will send us notes so that we have some follow-up. So she sent this note recently. Hi, Molly, Michelle, and Dante. I saw the patient today in my ICU follow-up clinic by telehealth. She was in and out of the MICU with hypotension and hypoxemia and a lot of delirium. She has been home since September, still recovering, but is just graduating from home PT to outpatient PT, able to walk around a little and very laboriously get up and down the stairs. Cognitively back to herself, also back to cooking in her kitchen at home, for which she is very grateful. She does not remember a lot about her ICU, but she does remember you, Dante, and how wonderful you were to her. Just wanted to let you know that you are appreciated and that she is doing well. Dante was the bedside nurse who was taking care of her. And when he got this email, he ran down to my office and said, "Oh my gosh, I remember her. So wonderful to hear that she was a challenging patient to take care of." But to get this feedback, this is the support that we need to give to our staff in the ICU. This is what we need to do to care for each other and to bolster each other. A short, quick email, but really made his day. And then it's going to make it just a teeny bit easier that next time to care for that difficult patient. So small things really can go a long way. We recently had another patient of ours who was on ECMO. She actually doesn't live in Boston. She was traveling to Boston for work and had influenza. She is totally comfortable with me sharing her story. This is her picture here and her mom's picture. She got influenza and then ARDS and was on ECMO for a prolonged period of time and then in our ICU for a long period of time. And when she left, she said, someday I'm going to walk back. She went back to Ohio and then she reached out to us and said, I want to walk back in to your ICU and I want to thank everyone. And we set up this whole day for her to come back in. And it was really empowering and inspiring for all of our staff to be able to see her walk. And she was a challenging patient on ECMO, in that there were constant goals of care discussion. Should we stop? It's been 30 days. It's been 60 days. She is not getting better. Like, when is the time to stop? How do we do this? And because she didn't live here, it was only her mom that was really here to support. And our nurses and our docs really circled around the mom and became the mom support too. And we did mostly every one of the home initiatives for this patient. Her name is Julie. And, we asked Julie about that. Tell us about these home initiatives. Tell us what we can do better. How can we make the experience more humanizing? And she shared this quote with us, which making sure that I still felt like a person I could tell was very important to this team, not just a patient, but I was actually a person. And this, for me as MICU director, is sort of one of the things that makes me most proud, when my team is able to treat everyone like the people, like the humans that they are, and not just the patients. And it's hard. And we all have moments where we lapse, myself included. But remembering that and having that be the culture and the tone of the unit, I think is so important. The last piece of this frame is caring for providers. And this could be a whole talk in and of itself. And I don't want to minimize it because it's so important. We all know that burnout is common in critical care and really has increased after COVID. But truly, I believe, as I shared with you before, that when we take the time to humanize the space, humanize the work environment for our patients and for our families, it makes it better for us as the providers. And we're humanizing the space for ourselves too. We've done some things both on the system level and sort of at the team and individual level to try to help care for providers. So, we have changed the way that we staff services to make sure people aren't caring for too many patients. We've changed the way that we schedule so that we give people more choice. We also get schedules out with more advanced notice so people can plan their lives. We do a lot of get-togethers outside the hospital. We have something called monthly resiliency rounds where we'll meet at a local sort of bar and food hall and get everyone together and just talk about ourselves as people, not as the workers that we are, but as people, and really get to know each other. And then we have wellness rounds monthly in the hospital with lunch where our social worker, sometimes our palliative care colleagues will join us, and we just have an open space and time for people to talk about difficult cases. And this is a nice way, in an interdisciplinary fashion, to just chat about things that have been hard or have been difficult that week. So, in summary, dehumanization is common in critical care. We cannot get around that. But what we can do, what all providers can do, is take steps to make the ICU a more human place for Miss A, Miss A's daughter, and Dr. X. And I just want to acknowledge Somnath Bose, who I mentioned already, who's our co-director and co-founder for the Center for Humanizing the ICU, and Elaine Klatt, who is our director of operations. And I just want to thank all of you for your time and attention, and I'm happy to take any questions. Thank you so much.
Thank you, Dr. Margaret, ma'am. That was a wonderful lecture, very insightful and something to think about. And I'm sure people will take away some of that and apply it to their ICUs the way they can. Thank you so much. So I request the viewers to type in any questions that they may have. So far, there are no questions. Maybe, ma'am, I can just put up a couple of points which would be of interest to everybody. So one of the key factors, and of course, you have talked about all this, but maybe we can just kind of re-emphasize on this. So one is, ma'am, talking about death. A lot of families do not want to accept death and have unrealistic expectations. So what is the best way for us to kind of approach such scenarios?
Yeah, so I think a lot of it is starting with training, right? And of course, there's a lot of geographical and cultural differences between the US and where you are. So knowing your culture and knowing how families want to communicate, and then creating training programs. So come up with scenarios, come up with simulations, and work on training the trainees. Get people comfortable, get the providers comfortable talking about death and dying on simulated patients or with each other, so that then when they're doing it in real time with the families, they feel more comfortable and they're empowered. And I think really teaching them the words. And again, very culturally specific and dependent, but here in the US, what we really teach is you have to use the word dying and death. The euphemisms are confusing and it's not as clear. And you can communicate with compassionate honesty. People always say, oh, death feels too harsh. I don't want to say that. I'm not being compassionate. But you can be honest and compassionate at the same time. So choose the words, I think, that work for you, that are meaningful for your families. And if they're not accepting it, a lot of it is just time and more communication and advanced communication techniques.
Thank you for the answer, ma'am. Then coming to family engagement, you talked about it a little. I think you showed a couple of slides. So how much of family engagement is good? Because it does reduce PICS, it reduces PICSF, but we have felt too much of family involvement is also counterproductive.
Absolutely. So I think you have to set boundaries with families. So we will sometimes have families join us for rounds. If they can't, we'll ask them to, call in and be on speakerphone. But we say, we're going to have you just listen. And at the end, we're going to give you 2 or 3 minutes to be able to ask some questions. But we very purposely have a rounding structure. And this is how we need to go through your loved one's care in a systematic fashion. And then, we also ask families and tell them we want you to be here at the bedside as much as possible, but there are times that we are going to ask you to step out, and we need you to do that because we need to do a turn, or we need to clean, or we need to do X, Y, or Z. So we are pretty explicit with the boundaries and the expectations for the family right up front. We have ICU welcome packets that we give to families that basically say, like, we want you to be part of the care team, but just exactly like you're saying, sometimes too much involvement or the incorrect involvement, it can be harmful. So we set those expectations right up front. They're written down in the ICU welcome packet, and then we also will verbally really talk about the expectations as well.
Thank you for the answer, Dr. Margaret, ma'am. Then coming to something, which is probably not there in the United States, someone coming to the ICU and playing the piano. But can we just, on a daily basis, maybe in the morning and evenings, play music on the PA system of the ICU? Do you think that should be incorporated in all ICUs, I think?
Yeah, definitely. So we do that. So on our All About Me posters, we ask people if they want to listen to music and what type of music they like, and then there's a computer in every room and we'll play it on the computer. The nurses will log into Spotify or YouTube or whatever they have. And I think it's really important. I think that it's not for everyone, so we need to make sure that we're doing it for the right type of patient and for people that want it. But I do think music is powerful and can be very healing.
Great, Dr. Margaret, ma'am. Thank you so much. It was wonderful, and we shall put it up on our YouTube for everybody, for the whole world to go through this. Thank you so much.
Thank you so much. I appreciate it.
Good night, ma'am.
Bye-bye.